and welcome to the inaugural DREAM Research Rounds. And DREAM is Disability Research in Academic Medicine. It is my absolute pleasure to introduce you to our speaker for the day. Dr. Chris Moreland is an academic hospitalist and associate professor of internal medicine at the University of Texas at Austin. He's also the associate program director and has been so for nearly a decade. His mentorship and his teaching have been recognized by learners and colleagues alike with awards at the institutional, regional, and national levels, including the Society of Hospital Medicine's Excellence in Teaching Award. His advocacy, publications, and presentations address health disparities and the workforce and workforce diversity, access to health education, and the effective use of accommodations for healthcare professionals with disabilities. He serves as the immediate past president of the Association of Medical Professionals with Disabilities, or as you may know it, AMFO. But I think most importantly, Dr. Chris Moreland is an exceptional human being, a lovely colleague, and a very treasured friend. It is my pleasure now to turn this over to Dr. Chris Moreland.
Thank you, Dr. Meeks, for that wonderful introduction. It's always a pleasure. I'd like to thank the audience for taking the time to join us today in discussing this topic. As a deaf person, I'm going to be signing my presentation, and we have interpreters here for accessibility. This presentation will talk about a recent study, patients and coworker mistreatment of physicians with disabilities. First, I'm going to talk about our objectives. To describe mistreatment experienced by physicians with disabilities, to compare rates of mistreatment of physicians with disabilities to those of their non-disabled peers, and list strategies to intervene and prevent mistreatment of physicians with disabilities. I'd like to acknowledge the research team included in this project. First, Dr. Meeks, who provided my warm introduction. Our excellent collaborators at the AAMC, the workforce study team. This was led by Michael Dell, who is the director. Additionally, Sarah Conrad, Zakia Nouri, and Zhao Hu. A little bit of background about how this study came to be. Several years ago, I attended an AAMC conference, the American Association of Medical Colleges Conference, where they addressed their State of the Workforce survey. That was presented by Michael Dell. At the end of the presentation, he described gaps in our knowledge that required more research. And one of those topics was physicians with disabilities. At that time, I approached him after his presentation to talk to him about his survey, particularly about deaf and hard of hearing medical students and residents. What began as an initial conversation ended up including Dr. Meeks and us providing recommendations for items to be included on their annual survey. First, before I go into this further, I'd like to talk about why we do this work. We have a literature review that says that physicians with disabilities are mistreated by both patients and their coworkers. That includes trainees, resident physicians, and medical students. Those physicians who identified as underrepresented and who have identities as underrepresented in the medical workforce include race, ethnicity, gender, sexual orientation, and they are at higher risk for mistreatment. prior research pertaining to connections among mistreatment were burnout and attrition. These physicians who experience mistreatment are 8 times more likely to report burnout and 4 times more likely to report having anxiety or depression. They're also at higher risk for reporting and having had suicidal ideation. Mistreatment clearly has implications for the health of physicians and the physician workforce. With this research, prior to this publication, we had no data that explained this phenomenon or this event as it pertains to physicians with disabilities. Physicians with disabilities are, let me back up. People with disabilities are underrepresented in the healthcare workforce. And we can see here along the bottom, that represents students, medical students with disabilities, which is about 8.3% of the population in the United States. That number gets smaller to about 7% when we look at residents. And that number decreases further when we look at physicians with disabilities in the workforce. So as we see the numbers decrease, we wonder why that happens. Now, for this survey, the AAMC, their workforce study team, conducts an annual survey called the NSSP, the National Sample Survey of Physicians. That sample group is approximately 6,000 practicing physicians who have completed training. That survey sample is weighted to represent physicians across the United States. And this is weighted for gender, specialty, age, and international medical graduate status. The data that we are analyzing here was conducted from February to March of 2020. In this survey, we included disability items, which began with a definition of disability based on the ADA, the Americans with Disabilities Act, as amended law of 2008. We asked, do you have a disability defined by the ADA? And respondents had an opportunity to choose from 8 different categories: ADHD, chronic health, deaf and hard of hearing, vision impairment, learning impairment, mobility impairment, psychological, or other. For questions addressing mistreatment, there were several. Well, first we asked about mistreatment in the last 12 months, the last year specifically, from either patients and or colleagues. The types of mistreatment that we specifically asked about were physical harm, threats of physical harm, unwanted sexual advances, and offensive comments regarding gender, sexual orientation, race, ethnicity, disability, or personal beliefs. We also asked about each of those in terms of how often they had experienced them within the past year. Never, once, 2 to 5 times, or more than 5 times. With that information, we dichotomized the analysis to either never or 1 or more times. We conducted a multivariate logistic regression analysis for the risk of mistreatment for physicians with versus without disabilities. This was controlled for various variables, including age, sexual orientation, marital status, race and ethnicity, employment type, primary care status, and IMG status. We also looked at whether or not people practice in private or academic practice. Thank you. In terms of our results, of the 6,000 people queried, 5,851 respondents answered disability items. Of those, 178, which equates to about 3.1%, reported having a disability. Here I'm using the acronym PWD to represent physicians with disabilities. So physicians with disabilities, when compared to physicians without disabilities, were significantly more likely to identify a race, ethnicity, sexual orientation, or other underrepresented identity within medicine. Of these physicians with disabilities, 64% experienced some sort of mistreatment in the last year, which puts them at a higher risk of mistreatment than the general physician population. Here we describe particular numbers, and I'd like to acknowledge Zaki and Nuri for developing the results as you see presented here. On the left in the white, you can see the various types of mistreatment. I'm not going to review each part of this chart. However, the light tan in the center, those results represent respondents' descriptions of mistreatment by their coworkers. In that middle section, the left-hand column of that middle section were physicians without disabilities, and the right side were physicians with disabilities. Now moving on to the far right columns in the blue, those represent mistreatment events reported when they were experienced from the patient, when they were initiated by the patient. I'd like to point out a few items here. First, if you would please note, in both the tan and the blue columns, physicians with disabilities for every item are substantially higher in number than physicians without disabilities. So sometimes the comparisons were one magnitude higher, one order of magnitude higher. In terms of threats of physical harm, we see that 27%, or over a quarter of physicians with disabilities, reported having been threatened with physical harm from coworkers in the last year, compared to less than 5% of their non-disabled peers. In terms of threats of physical harm from patients, physicians with disabilities were 40% higher than physicians, or excuse me, 40% reported experiencing threats of harm from patients versus 22%, approximately 22% of physicians without disabilities. When we discuss the actual physical harm that physicians have experienced in the last year, physicians with disabilities were approximately a quarter of that population reported having experienced that, compared to less than 2% of physicians without disabilities. Those numbers are roughly similar when we look at the experiences of physicians experiencing such events initiated by patients. Physicians with disabilities were more than 30% more likely, or reported approximately 30%. Let me back up, I'm sorry. Physicians with disabilities reported experiencing unwanted sexual advances over 30% of the time for both groups. as initiated from coworkers and from patients. So this last information, I'm going to translate that to the odds ratios. This graph is taken from our publication, and this represents the odd ratios. At the top is coworkers, and at the bottom is patients. Every item described here has an odds ratio, including a confidence interval to the right of 1. So all were statistically significantly higher in terms of risk for physicians with disabilities compared to their non-disabled peers. And again, I'm going to describe a couple of numbers here on this chart. Physicians with disabilities were approximately 8 times more likely to have been threatened with physical harm by coworkers, and more than twice as likely from patients when compared to physicians without disabilities. Disabled physicians were also more than 16 times more likely to have been physically harmed by coworkers, and more than 6 times more likely to have been harmed by patients. So what's happening here? So I'm going to discuss our results in terms of some other work that has been done. Our results aren't acceptable. These events describe complex interactions of physicians with disabilities and their needs, as well as representing their fears and their needs for access, disclosure of disability, and maybe disclosure of a need for accommodation, which can translate to support of some kind. Now, how do physicians with disabilities balance their needs with the fears of being stereotyped, of experiencing the results of conscious or unconscious bias from colleagues and or patients, and even retaliation of some form? It seems that those fears, unfortunately, are very well founded, as evidenced by this data. Before we move on to talk further about this, I'm going to pivot to another study that was reported earlier this year. Our paper was published in Health Affairs some 2 or 3 weeks ago. This study was a report from the AAMC and was published in July of 2022. And you can see the image here that I'll describe briefly. The title is Understanding and Addressing Sexual Harassment in Academic Medicine. And on the left, there's an abstract image of an individual writing on a clipboard that appears to be a female. Approximately 22% of all faculty and 34% of female faculty experienced sexual harassment in the workplace. There were higher rates of sexual harassment experienced by faculty who identified as race, ethnicity, or a sexual orientation that was underrepresented in the workforce. This report shows that those faculty that experienced harassment were less likely to be engaged or satisfied with their workplace. They were less likely to remain at their institution. And the faculty in this survey reported having concerns about whether they were safe in their ability to report experiences with harassment to their leadership. And they also expressed concerns about whether anything would even be done should they report. This report also included interviews with a variety of leaders in academic medicine, and identified several strategies to address this. The first strategy emphasized was prevention, addressing and preventing sexual harassment before it even happened in the workplace. Also, we emphasized weaving anti-harassment policies and behaviors throughout the workforce. That includes policies, procedures, reporting strategies, whether this is for faculty, staff, or trainees. We also acknowledge that accountability needs to be reinforced among the leadership. We recognize that they are responsible for preventing and addressing sexual harassment. And the concept of strategies in terms of sexual harassment needs to be woven into the diversity and equity and inclusion pathways. Now I'm going to move back to our initial discussion about disabilities. It's important that we acknowledge our findings that physicians with disabilities are often represented or often identified as having other identities that are typically considered to be underrepresented identities within medicine. We have diversity within our community. And not only do we need to talk about the different forms of disability, so for example, how a deaf or hard of hearing person or a person with a visual disability or a cognitive/learning disability might experience these events of mistreatment and how they will experience them differently. We also want to acknowledge the importance of describing potential intersectional identities. And we've only just begun to address that with some of our data when we look at other underrepresented identities, such as race, that's underrepresented in medicine. So how do we address mistreatment? There are several strategies that we can consider. And these strategies need to be discussed and implemented now. First, we need to collect data. And the reason we know about this information and this data is because we're counting it. And that's a result of advocacy for people with disabilities to be included within the national survey. We need to collect data across the educational and practice continuum, from those that are applying to medical profession schools, to those that are in training, in residency, and in practice. We also need to keep in mind why people leave the institution if and when they leave, and evaluate their experiences afterwards. Physicians with disabilities, that data should not be isolated from the other data we collect. We need to conduct disability training. As I acknowledged with the prior report that I discussed from the AAMC, we need to conduct disability-related training and anti-ableist training, and that training needs to be incorporated for everybody: faculty, staff, consultants, learners, the whole spectrum. One important concept is that of bystander training. If we witness an event that can be described as mistreatment, whether it's by a physician or somebody else, to a person with a disability or somebody else, how should we intervene as an individual? How can we become effective allies? How do we advocate, both in the moment and after the event? How do we debrief after that event with that person as they went through that experience? So I'm advocating incorporating this type of training across the institution, both locally, nationally, and as well internationally. Third, we need to develop and increase our inclusion efforts. Over the last 10 to 20 years, we have seen some excellent efforts to increase the inclusion of those who are underrepresented in the healthcare workforce. But there still remains quite a bit of work to be done. We need to ensure that physicians with disabilities are included in those efforts as well. That inclusion, we often discuss inclusion by meaning people in terms of recruiting them to medical school, into residency programs, and successfully graduating and matriculating through the educational continuum and their programs. And that's one part of it. However, when we look at inclusion, we need to also include the level of those the leaders in leadership and those who make decisions. Policies are often developed, informed, and implemented by those individuals and enforced by those individuals. So we need to engage people with disabilities within those efforts to make sure that their perspectives and lived experiences are included. Fourth, we need to implement and sustain reporting. And by reporting, I don't mean reporting the data. That's part of what we need to do. And that goes back to what I addressed in the first point on this slide. But we need to address and report events when somebody experiences mistreatment. As was previously acknowledged by the AAMC report on sexual harassment, many people, faculty in particular, express concerns about whether or not they can report such events and experiences safely without fear of retaliation. Every institution, every office should explore how those reporting systems are structured, how those reporting systems are used, how people disclose that information, how the institution follows up on those reports. How do we ensure that physicians with disabilities are experiencing environments of physical and psychological safety? This work is being done, but we need to further the work by including people with disabilities. I'd like to talk a little bit about the idea of belonging. First, I'm going to quote Dr. Laura Roberts, who is the editor-in-chief of the Journal of Academic Medicine. She says it well. Respectful inclusion in the health professions of individuals with a wide range of backgrounds, identities, and life experience is increasingly understood for its primacy in preparing an innovative and representative workforce, addressing health disparities, advancing science, and serving the needs of the public. Respectful inclusion is vital to the future of medicine and requires new ideas and new practices. Later in that same manuscript, she goes on to say, committing to a more diverse and vibrant future requires self-honesty, creativity, and courage in tackling aspects of the culture of medicine that may interfere with people from all backgrounds feeling welcomed, included, and valued, namely, feeling that they truly belong. How can somebody feel a sense of belonging when they fear mistreatment or harm? So these are some additional strategies from what I talked about earlier. We need to be forward-looking. We need to foster inclusion and a sense of belonging for everyone, and a sense that you should be here, you deserve to be here. First, we need to align how public-facing materials, we need to align our public-facing materials with institutional practices. So for example, if I am interested in applying to a particular med school, I will probably look at what their technical standards document says, at least in the United States. Those documents describe skills and competencies that are needed to successfully matriculate through medical school education. That document describes a sense of welcoming for people with disabilities. Does that provide me with a way to request accommodations that I need? Then we need to look at our experiences on the ground. Do those experiences fit the information in that technical standards document? One concept that's become increasingly important is the concept of universal design or universal access design. We see universal access design becoming more recognized within a variety of changes over the last several years. For example, if we talk about curb cuts or captioning on public TV, captioning was initially designed with deaf and hard of hearing people in mind, but now the general public takes advantage of closed captions. Spaces where we work and learn should be designed with an awareness of people with disabilities, and consider them before these people even enter the space. So for example, when we think about conference experiences, so when we see the projection of the presenter on the screen, are there captions also on the screen? We need to ensure that spaces are physically accessible for people with mobility disabilities, as well as for people with cognitive or psychological disabilities. We need to incorporate disability within justice, equity, diversity, and inclusion initiatives. Many institutions and organizations currently have offices and teams that address DEI efforts. We still haven't adequately incorporated disability into this work and into these offices. Last, I'd like to encourage teams from small offices and staff within larger institutions to seek out the experiences of people with disabilities within that institution or even nationally and elsewhere that can help to inform and make the workplace design and experiences better for all. And that should also be included in decision-making. People with disabilities are at much higher risk for mistreatment from patients and coworkers. And this is an issue that we need to address. And this is a problem that we should feel that we can solve. I want to thank you for taking the time today to join us. I want to thank Dr. Meeks and the AAMC workforce team. And you are welcome to contact me. Here is my contact information on the screen.
Thank you so much, Dr. Moreland. This is a really important study, and we